Good afternoon, everyone. It's a great honor to be part of this symposium, How I Do It in Complex Pancreatic Surgery. My name is Adeodatus Yuda Handaya from Yogyakarta, Indonesia. Today, I would like to share our perspective on how to encourage and develop readiness for complex pancreatic surgery, not only through techniques, but also through mindset, system, and teamwork that make these operations safe and reproducible. Complex pancreatic surgery means procedures beyond standard resections. Those that involve critical vascular structures, carry high risk of complications, or require exceptional technical difficulty. In our practice, this includes borderline resectable tumors, arterial or venous involvement, and redo pancreatic operations. These are not just surgeries, they are team missions requiring coordination and discipline. Complexity can arise from several aspects: tumor location, procedure type, anatomic involvement, risk of complications, resource needs, and outcomes. Tumors invading the SMA, SMV, or PV, high risk of POPF, and the demand for high-volume centers all contribute to difficulty. The key question is not can we do it, but how do we prepare the environment to do it safely? One principle always reminds us we cannot avoid the complex. We must be ready to face it. Complexity is inevitable. Readiness means not rushing into surgery, but building strong systems, well-trained teams, and the right mindset to face it confidently. Across Asia, only 10 to 30% of pancreatic cancers are resectable at diagnosis. In Korea, about 20%. In China, almost 80% present with advanced disease. This shows that most patients already arrive in complex stages. Therefore, improving surgical skill alone is not enough. We must strengthen early detection and regional referral systems. In Asia, 60 to 80% of tumors occur in the head of the pancreas, often detected earlier due to jaundice, leading to higher resection rates. In contrast, body or tail lesions are found later, frequently metastatic. Complexity is therefore not only technical but also biological and systemic. Typical tumor size at resection is around 3 centimeters. But remember, resectability is determined not by size but by the absence of metastasis or vascular invasion. Even a small tumor can be technically challenging if it lies near major vessels or deep anatomic planes. Resectability requires no distant metastasis and no unreconstructable vascular invasion. Large tumors may still be resectable if vessels are free or reconstructable. Neoadjuvant therapy helps improve R0 rates. For multifocal disease, total pancreatectomy may be necessary, guided by intraoperative frozen section and multidisciplinary discussion. In Indonesia, robotic pancreatic surgery remains limited due to high cost, no insurance coverage, few trained surgeons, and low case volume. It highlights that technology alone is insufficient. What truly matters is creating a sustainable ecosystem that combines training, policy, and regional data. Pancreaticoduodenectomy services are centralized in Type A referral hospitals, mostly in major urban areas. Type B hospitals perform it selectively, while Type C hospitals only refer or stabilize patients. The result is a geographic inequality: concentration in Java and Sumatra, limited access in eastern Indonesia. The challenge is not capability, it's systemic distribution. In this context, both open and minimally invasive approaches play vital roles. Open pancreatic surgery remains the cornerstone for complex, vascular, and redo cases. Minimally invasive or robotic techniques are safe and effective for selected patients at high-volume centers. The goal is not to choose one over the other, but to know when and how to use each safely. Let me share a few representative cases from our institution. real examples of complexity, adaptability, and teamwork in an Asian setting. A 25-year-old female with a 17-centimeter distal pancreatic tumor. We performed a distal pancreatectomy. The tumor distorted normal anatomy and carried a high bleeding risk. Successful outcome was possible only through coordinated teamwork and vascular preparedness. In complex surgery, institutional readiness matters as much as surgical skill. The second case had multifocal pancreatic lesions. Intraoperative frozen section confirmed additional foci, leading to total pancreatectomy. It demonstrated how real-time decision-making and flexibility are vital. Surgical courage must always be guided by clinical wisdom and collaboration. The third case involved a large distal tumor invading the posterior stomach wall. We performed distal pancreatectomy, splenectomy, and partial gastrectomy. High risk of bleeding, altered anatomy, yet safe results through disciplined teamwork. Complexity is universal. What differs is how we prepare our system to face it. One key aspect of safety is preventing catastrophic complications. For high-risk cases, we routinely use external drains for both CBD and PD to reduce the risk of POPF and hemorrhage. It's a simple yet powerful rule. When in doubt, drain, protect, and reassess. Small decisions make a big difference. Moving forward, the path to growth and excellence depends on 4 pillars. 1. Multidisciplinary team decisions for every complex case. Intraoperative frozen section for real-time margin control. The proactive prevention of POPF and bleeding. 4. Continuous mastery of open surgery. Excellence is not defined by adopting every new tool. It's about mastering fundamentals, ensuring safety, and learning together as a team. To conclude, I'd like to return to that simple message. We cannot avoid the complex, we must be ready to face it. Developing complex pancreatic surgery in Asia is about readiness of the surgeon, the system, and the team. Through collaboration, mentorship, and shared learning across our region, we can make complex pancreatic surgery safer, equitable, and sustainable. Thank you very much for your attention.